don't know how to do that.
Share the screen.
You can share the screen with programs.
Okay.
Yeah.
老师好，可以开始了。是。
The program will be recorded and will be on YouTube and also on Indonesia television online. Yeah, we have hello, good morning, Professor Rao from India.
Good morning, Professor
You look
Chang.
great. You look great.
You look great.
Good morning.
Thank you so much.
Good morning. Oh, hi, good morning, Professor Shi.
Yes, good morning.
Oh, you look great.
Everybody,
How are you this morning?
Dr. Chen,
Yes.
President of Taiwan Public Health Association, and Peter, my lover.
We have many of your friends online
great.
now.
You are great.
Yeah.
High time action, very good.
And you remember Annie Rashmani from Indonesia? Now she's the Dean of Health Sciences in
Hi,
Uniters.
how are you?
Hello.
Hi,
What's going
nice to
on?
meet you here in the air,
Yes.
in the cloud.
Many years ago, she's still a doctor student in Taipei Medical University. You
Yes.
remember?
Yeah.
I
Now
remember,
she
yes.
has become a very important faculty of the university.
Yeah.
Very successful.
Thank you.
Thank you.
You also studied at the Asian University?
I'm from Udinose Prof.
Okay.
Okay, we got
Because
one more minute. So if you may open up the screen, if you already, we may take a group photo. I mean, Zhen, would you like to? Okay, good morning, Professor Zhang.
Yeah, good morning.
Good morning. Thank you for joining us. You'll be the first speaker, I guess.
Okay.
Professor Chen Xiuxi, good morning.
Morning, Peter.
Yeah.
Good morning.
Good
Good morning, everyone. Good
You
morning,
are
everyone.
in the office. You are working in the office. It's not a Saturday for you. Okay.
现在是公卫生协会理事长，
工业师学会里
公共卫生协会台湾台大的
陈寿是
教授。
All right. Yahui, you may start. Yahui, you can start now.
好。
Okay. If we may start on time, I know many people are here, but they are not open up their screen. If they would open the screen, we can see each other.
这个就是张文
I'm Peter Chang, and I am now in Ho Chi Minh City. I'm very happy to invite you to join this Cross Asia. I think we have 7, 8 countries. There are many others join online, but not join the debate at this moment. So thanks to Taiwan Society of Public Health, Taiwan Public Health Association, and I am on behalf of the Asian Health Literacy Association, as well as Taiwan Association for Health Literacy and Communication, which is presented by the Professor Terence Chai in Taichung. And also we have a Taiwan Education Science Culture Organization together organize this conference, this online conference, which is a prospect for COVID-19 pandemic online forum in the country and in the region. Well, you know that Europe and North America started having big pandemic. And then now in Asia, many countries in Asia now was heavily hit by the COVID-19. But we have to walk out of the the trike as soon as possible. And I think the best way is to learn from each other. How are the strategy? What will be the best experience and strategy, and how we are going to look for how can we have a virus-free Christmas? We are going to have that. I am now in Ho Chi Minh City. Vietnam now is in deep water, deep hot water. I hope they will overcome the crisis as soon as possible. We'll hope to learn from each other. So that's the reason we have this organization. And I would appreciate the speaker. Let me name the speakers. Professor Chuan Chen Zhang from National Taiwan University. We have Professor Xiuxi Chen from National Taiwan University. We have Professor He Mei Xiang from Taiwan Sinica Academia. We have Professor Jaga Sakhan from New Public Health Association, Mongolia. She will speak later on. We have Professor Ming-Si Li from Taiwan National Health Research Institute. We have also have a very important scientist, director, Professor Yi-Jun Luo from Taiwan Center for Disease Control. And we also have an international speaker from Malaysia, Professor Awang Mujiba, Awang Mohammed. He will speak later on. We are having Annie Rashmani from Indonesia, University Diana Ruswangtora, Dinas. As well as we have Professor Chanong Tong Hang Song Gang from Mahidol University, Thailand, and also have Professor Tumang Duen. He's from Vietnam, but now he's teaching in Taipei Medical University, also Vice President of ACLA. And finally, we have Professor Arati Rao from Manipur Academy of Higher Education, India. These are the speakers. And now I would like to present Professor Pao Zhong Chen, the President of Taiwan Public Health Association, and he will chair the first half of the session. Professor Chen, you're welcome.
Okay, good morning, everyone. I'm Bao Zhong Chen from the Taiwan Public Health Association. I think I'm very happy to join this very important online forum. So it's my great pleasure, especially co-organized with the Professor Zhang, because he invited us to join this very important symposium. So I think in Asia, I think that we may we have a different race, different lifestyle, a different development, even the different social situation. But we are facing the big enemy for COVID-19. So no country can be safe until everyone is safe. So I think it's very important. We need the global response, global cooperation. It's needed to end this COVID-19 pandemic. So today we also invite the 5 speakers from the Taiwan, not only from the academic organization, also from the our government. So I would like to chair the first half, the section. So to follow the surname alphabetical order. So I would like to invite the first speaker, Chang Chen Zhan, first. He's our former dean of National Taiwan University College of Public Health. Now still is our very energetic professor in the COVID-19 epidemic, the issue. So Professor Zhang, welcome.
Okay. Thank you, Professor Chen and Professor Zhang, for this wonderful conference. I was thinking what I'm going to talk today, and in 5 to 7 minutes, And I think I want to look at this issue from our regional perspective. And I would say my conclusion is, we are, as a region, Asia, is given an unprecedented opportunity to show in the world that our excellent performance in containing COVID-19 could provide global health a new direction and new possibility. So I'm really interested to learn the current development in each of your countries and take a more positive view that actually we can contribute to global health. So I coin this as our Asian models of COVID control and its global implications. As we can recall last year, that in the ongoing pandemic of COVID-19, our region stands out as a leading area in preventing any major outbreaks. If you compare to Europe and US, North America or South America, we stand out quite successful. The reason for that is we implement quite successful non-pharmaceutical interventions, especially border control in a very early stage for each country to do so. Not to mention the contact tracings, mask wearing, and social distancing that are implemented in each individual countries. So that seems to be very easy for us. It's actually very difficult for many Western countries to do. And its cultures, it's, mostly cultures, I think, that our attitude towards infectious disease is quite different from Westerners based on many, many reasons, historically, morally, and socially. But that comes with a very big toll. In our regions, we have to rely on transportation of goods and people to make our region prosperous. So after almost 1.5 years border control of each countries, our citizens suffer a lot, especially those people with lower incomes, less educated. They suffer a lot from this pandemic because of the border control that affects economies in many countries, which rely mostly on export of goods to other countries or export of labors to other countries. So that's one thing we have to think. How can we build on previous success model to move forward? And in terms of current epidemic caused by Delta variants in our regions, we make some mistakes together. When we had a success back in last June, countries become more complacent on controlling the original variants from Wuhan. And even though there is some alpha variants going around, we still rely on measures that make us successful in the first round. And when the Delta variant was cooked and spread from India, and we never thought we had to prepare last winter. So starting this sprint, I think one country by one country, we find out the original non-pharmaceutical interventions measures is insufficient to contain the outbreak to the low levels as we like. Well, we Asians has very low tolerance of cases in our societies. most of the time, if you compare to UK or US or like Brazil, our instances rates are not high. However, from Northeast Asia to South Asia countries, we can only tolerate less than 100 or less than 1,000 cases per day. That's if we want to do this, then we have to implement even more stricter measures we never imagined before. Namely, mass testing. You have to increase mass testing. That's the way we have to do, and we have to apply now the most readily weapons of controlling this pandemic, which is vaccines. Unfortunately, the majority of countries in our regions will not deploy sufficient vaccines as we like. So that's some of the weakness we are sharing in our regions. But don't be to be sad about this. I think we as a regions, if we can improve on what we have now and to do something more that we need, then we probably can have something better in preparing even another variant that's experts estimate is definitely come. And we have to do it from now. And what we should have to do, if you think of what we are lacking in our region, is international cooperations on like science-based approach and also this intergovernmental coordinations. Think about Europe. They have EU. They have formed a bloc that they can work together. And United States is a federation of many states, and they can coordinate to do supply chain and etc. Not to mention the big scientific instrumentation institutions they have to do this science-based approach. In Asia, we are lacking this kind of scientific cooperations in a very efficient way. So the wisdoms from countries are not shared timely, and most of the time, our knowledge and our scientific findings has to be channeled to mostly UK and US to get published in English in US or UK-based journals. Then those information then channel back to our society and be translated locally to our society. I think that takes too long. So I have always advocated we have to have regional scientific associations in this, and global health is one thing, in particular in this infectious disease control. We have to form this. So today's conference is Professor Peter Chan and Bao Zhongchen organized. I think it's a very good first step. We have to do this. And it creates us a lot of possibility now because COVID-19 is changing the world and changing every one of us. And what are we going to move from now to so-called post-COVID normalcy? There's many possibilities. International organization, governmental or non-governmentals, has to be changed to according to this pandemic. And we all know that country borders will become less and less meaningful in the futures, and disciplined boundary has also need to be broken, not be broken, to have more interdisciplines. So I watch country by countries, and we have come up some of good examples from our regions. like Singapore, is trying to treat this disease as a flu. So it's a flu-like control way. And New Zealand just came out with so-called continuing eliminations strategies that treat this pandemic as a measles, okay? So flus and measles are all old pandemic we are so familiar with. And through today's conference, I really like to learn from each individual countries what kind of like infectious disease models we can come out. And if we can integrate all the best practice in our regions, probably we can show the world in this ongoing pandemic that the Asians model will prevail, and in the futures that we really can contribute to global health with our efforts. And I think I have to come back to the science base, that in the coming 1 or 2 years, our region has to come out with some kind of vaccines research, development, and productions possibility to occupy the supply chain of global needs. This is what we need in our region, but we are lack of. India leads the way of producing a lot, but it seems to us until now it's not sufficient. We still need more. And I heard that Vietnam's like Korea and also Singapore are doing this. We are in Taiwan are also invest a lot in doing this. So I think that's supply chain of vaccines of all kinds in the futures will be very important for our success to become a even more successful story. So with this, I will come back again to say that we are given a very big challenge, but also a big opportunity to contribute to global health in the 21st centuries through these global health corporations. With this, I wish everybody safe and healthy. Thank you very much.
Okay, thank you, Chang Chen's talk. And because we have the Q&A in end of our program, so I would like to introduce the second speaker from Taiwan, Dr. Xiuxi Chen. Professor Chen, also our professor of the National Taiwan University College of Public Health. He's our former deputy dean of College of Public Health. Welcome, Xiuxi. Xiuxi, is that okay?
Yeah.
Can
Okay.
you? Yeah.
Okay.
Thank you so much. Good morning. Thank you, Peter, and also Baozhong to invite me to attend these meetings. And yeah, I just want to get my slide. So wait a minute. Yeah. Okay. Can all of you see my slide?
Yes.
Yes.
Yeah. Can I use my slide to give a very brief, introduction about the talk, and then then we can have a shared experience with each others in Asian countries. Yeah. First of all, I think following the Professor Zhang, the very valuable remarks, I think we still have many things to learn, from this COVID-19 pandemic. And I just want to show you this is a framework I use to work all the time and from time to time, to to study and to provide the information for international research people or the domestic country people who are interested in containing the COVID-19. Yeah, I think basically I know COVID-19 pandemic has already surprised all of us, but we need to also go back to the basic about how they look at from population levels, from household until global pandemicals, and also to see the individual level when they get the COVID-19 disease and how they treat them and how they recover and to avoid the deaths. So this is actually a challenging job. So as an epidemiologist like me, in the traditional way, we always use the one of the indicator reproductive numbers to indicate the spread of the SARS-CoV-19 too, by looking into the three determinants, including the contact rate, transmission probability, and also the infection period. So using these indicators to assess the spread, then we can have the corresponding interventions, including, the NPI. You already heard about that from Professor Zhang, and also the antivirus therapies for reducing transmission probability and also reducing the period of infectiousness. And of course, the final weapons, the best weapons, very well is about vaccine, can reduce, the contact, reduce transmission, and reduce the infectious period. So I think even right now, we have so many uncertainty to face with the COVID-19 pandemic. I think we still need this map to provide the precision, the control for containing these changing variant of virus. So that's why we have the reproductive number unknown and also RT. RT is at the bottom panels, and after the interventions, the RT, the unknown will reduce to RT. So this is the first articles I work with also Professor Chang Xianzhang about how to use the material from the Diamond Princess cruise ship to demonstrate in the closed setting and semi-closed settings. You can see it's the high unknown values, which surprise us because we never seen such kind of the droplet infections with so high the unknown means is one case can have about around 6 cases of the spinning. So after that, people use the NPI because we don't have a vaccine at the moment, at that time. So you see the NPI after the implementation of the NPI, you see the reproductive numbers has been reduced to about 3, and the NPI has demonstrated very useful means and useful the containment measures. And they, of course, they have different NPI. We can have a discussion, from different from different places by different settings. But right now, you see, as a virus change from time to time, so there is a variant of the interest and variant of the concern, and you can see the the reproductive number increase from 5 even to 8. So it's like the measles. It's like the the rubella, something about the airborne transmission. So it's quite, it's quite transmissible. So that's why, there's so many waves of the epidemics happening after the June 2021. So in terms of the transmission mode, how can we have continuous COVID-19 pandemics? People always ask. And I think in summary, the transmission route always from the imported case through household, and then spread to the nosocomial infection. Then you have a community acquired. Then you have a global pandemics. So in Taiwan, we already learned from Alpha virus about the household infections. If you see this slide, the household infections increased from 43% in 2020s about the wild type until you can see a 60, even 70% right now in the household infection. That's why we have the epidemics in between April until the June, and the control later on. So 2020 is our very successful experience in containing COVID-19. You can see the majority case has the imported case and very few domestic case with the green. But until you see the about the May, then we have 2 hotspots, to have epidemics. So I use again the technique of the technique of calculating the reproductive numbers. So we demonstrate that alpha actually unknown equals to 5.5 is about 6. And that's why it's planned, the epidemic spread from 2 hotspots to other countries in Taiwan. However, Taiwan, right now has very successful in containing, these epidemics through, NPI, and also through the screening, rapid screening test. And then you can see the magnitude of the case decrease from about 400 until so far we reduced to about 1, even within the 0.1 case. So this demonstrates actually we need to have the multiple containment measurement, to contain, COVID-19. And I just show you 3 cases. The 2 hotspots, Taipei and the new Taipei, use a very rapid screening test to open the community survey screening to reduce, the case. And also we have a Surin, the foreign neighbors, community acquired infection as well. And due to the rapid screening test, you see, we also have such a control. And
okay,
we use the model.
So please, the time is limited. Thank you.
Yeah, I know. I will finish this slide, then get it back to you. Okay.
Thank you.
Yeah, this is the final slide. Okay, the final slide just show you, Taiwan has a very good, the control patterns, but in the Western countries we have the UK and USA and also Spain. They also have very good control, but right now they have a rising epidemic because of the vaccination breakthrough, and this is another pattern. And also the final, the third column, you can see we have also some more countries with very large epidemic because of the insufficient vaccine. So that's cause, in addition to MPI and also the screening, we need to have to get even distribution of vaccine around the world in order to reduce the epidemic in each countries to balance the global to reduce global pandemics. Okay, Peter. Yeah, I get back to you. I'm sorry. I don't know before you don't need slide. Yeah.
Yes. I think thank you. The presentation. I think she offered a lot of the information there. If the Professor Chen agree, I think we may offer this slide to our speaker. Okay, thank you again.
No problem. Yeah, no problem. Yeah, sorry.
Our next speaker is the Mei Xianghe. She's a investigator of the Seneca Academia Seneca, Taiwan. She's the expert in infectious disease epidemiology. So welcome, Dr. He.
Xiaoxi, you may
Close
yeah,
your
okay. Thank
screen.
you. Professor He Meixiang, you may open the microphone.
Now, can you hear me?
Yes.
Okay.
Yes.
Good morning, everybody. I would like to briefly share with you 3 points that I see are important in some of my views. First thing, I would like to go back to the origin of all emerging infectious diseases and how we might be able to be in the future to stop such of this or prevent this sort of damage or minimize the damage of new infectious diseases. Second of all, I would like to stress the importance of epicenter, the concept of epicenter. Third, I would like to share with you what I think is a very small event in Taiwan, which I call is the best practices. Maybe I start with the very last one. We see that Delta virus, the new variant, it has gone through the world with no stopping at anywhere. Wherever it goes, it spreads. And in fact, we have encountered Delta in Taiwan, but as soon as it was discovered, we were able to, at the very local site, implement what we call level 4 control measure. That means everyone stays home and food is delivered to you. We were very fortunate this occurred in a very rural site, but we were very good at detecting it at very early on. So in the end, there were only some 17, 16 cases, and we were able to stop it immediately. I can see that I just tell our people that if today, this occurred about a month ago, I tell my people that if today we still have Delta in our community, our life will be very, very, very different. So we were able, and the sort of the decision that was made, even up to now, I look back, I'm very impressed that it was implemented at the local site by a sort of a very district mayor who just say, we go into level 4, we do all this, and he asked for help. And we were able to detect all the cases with mass screening, and then it was stopped at the local site. So that occurred about a month ago. So that's what's happening in Taiwan. So is Delta unstoppable? Well, if you can detect it early, and it's possible. So now it comes back to the concept of epicenter, because no matter how big this pandemic is, it goes global everywhere. Wherever it starts, there is always the site of the beginning, and locally, wherever it is, if you are able to detect it early. Very unfortunate that COVID-19 the infected people, half of them are asymptomatic. Another nearly half would be very mild cases. And then by the time you see a very severe case come to medical center, you already have 80% of the people out there. However many sick people you see in the hospital, you're missing 8 times of it, basically. So that's the real problem. If you don't detect the first sick case, you detect first 10 sick cases, then you have 100 people out there. So that's really what we are dealing with. So an epicenter also, we can think of what it really is. When we look back in the history, 1918, I looked at the death rate. I looked at the death rate of all major metropolitan cities at that time, like New York, London, Paris, etc. And the death rate was extraordinarily high. The death rate was higher than each city. The death rate was higher than the average of the country. That really shows most of the epidemic starts at the densely populated urban area, even at 100 years ago, basically. So we still, when you have vaccine, when you still need to focus on the very densely populated area. When we talk about different countries, really we think of the epidemic ongoing in the country, we think of an average, but really what's experienced is in each local site. We can think back last year in March, how New York City was suffering at that time. And that was because it was the front encounter the virus of that country. So now I come back to the very last part, is the origin. I would like to discuss this because seeing it from the infectious disease point of view, I'm an infectious disease doctor, although I don't practice medicine. I'm a public health practitioner in a way. So we really come to the understanding that the important new emerging infectious diseases, most of them come from zoonotic origin. And the important thing is that these ones that we have never encountered before, usually these viruses co-evolve with an animal which maybe have not been cohabitate with us for long, but with our expansion of population, etc., that we now come to contact with them. Or previously, the most important thing is that I believe the marketplace is still plays a very important role in the modern day. In the old days, obviously zoonotic, disease that cross-species infection took place, I'm sure, in the past history. But because of the lifestyle at that time, maybe a local site, a few people died, and then it stopped right there. But now we have markets that sells the life stock. And I know that this is really the practice and the sort of traditional culinary of our Asian people. We really love those games, the wild games, and we looked at the live ones and have it killed and then cooked for us, in a very short time. So you have all these wild games in market, and then that's mingled with some other susceptible wild games, and then you have people around. I'm sure this type of practice plays a very important role. It really comes down to the very basics. One could just think of it as food safety. Basically, you supply, all this meat you supply, how you butcher it, the way how it might be controlled, so this is something we really need to rethink of it. Basically, we respect the traditional sort of culinary, the eating habit we have, but when it becomes a real threat with the current situation, the whole modern life, that it can if the disease crosses species to human, and it's very easy to spread. You have modern hospitals in the site, and then hospital is a very important infectious disease spreading site, and then we have international travel so heavily, so etc. So this is something I think we really, when we settled with COVID-19, we really have to come back, think about all these issues. So these are the sort of three things in a very quick way. I just want to share with you my thoughts. So thank you for your listening.
Thank you, Dr. Ho. The talk is very give our very important the key points. Especially, we are happy to stop the Delta variants in the very early stage. It's our good the story to share with the other country, the experts. So next one, we like to invite the Min-Xi Li, Dr. Li. Currently is also the investigator of National Institute of Infectious Disease under the National Health Research Institute, Taiwan. So welcome, Dr. Li.
Okay. Yes, I'm Min-Xi Li. I would like to talk a little bit of the in the Asia Pacific. We are very limited capacity for vaccine production. So, and Taiwan have this issue for over 30 years. 30 years ago, Taiwan is a local vaccine company.
Professor, you see, your connection is not good. Your connection is not good.
Okay, I'll turn off the camera. Maybe it's better. Is it better now?
We will see.
Better now.
Let me see.
Is it better now?
Not much.
No.
Not much.
Okay. Not much. Okay, sorry. Let me finish very quick. The vaccine issue is a very tough issue, and so we are several years ago we tried to establish the Asia Pacific Network for antivirus surveillance, and we help the local vaccine industry in Taiwan to conduct clinical trial in Vietnam. I think it's a good way to help each other to build the alliance of the vaccine industry, and also to help each other in the future. So in the future, we are trying to establish Taiwan Association for Vaccine Industry very soon. And after that, we will try to establish alliance with other Asia countries to get an alliance for the vaccine industry, because the vaccine industry is very unique. It's different from the pharmaceutical. So it's need a little of integration and networking to help the vaccine industry in Asia Pacific countries. Okay, I will finish here and hope to share more information with you in the future.
Okay, thank you, Dr. Li. And so also very sorry to not unclear the sound, the listening. Okay, I think the next speaker from the Taiwan CDC, the Eugene Luo. Now currently he's the Deputy Director General of Taiwan CDC. Welcome, Dr. Luo.
Thank you, Chair. I represent Taiwan CDC, the government part of the outbreak response. So my quick talk will focus on three parts. Number one, the outbreak characteristics that Taiwan has just experienced. It's an alpha strain outbreak over a 3 month period. Second is the outbreak response and lessons learned. And third is our vaccination progress, and also some closing remarks. So the first part, Taiwan used to have a very low community transmission or even suppressed level, but since mid-May, we have entered a new phase, the largest alpha strain domestic outbreak including widespread community transmission, mainly in Taipei metro area. As of today, we have more than 15,000 confirmed cases just over the past 3 months, mostly occurring during May to June. The age group preferentially affected the elderly population, with more than 50% cases in the age group above 50 years old. And we have been successfully implementing those NPIs, non-pharmaceutical interventions, to suppress the reproductive number all the way from 3.3 to recently lower than 0.7. So for the past 1 week, we have recorded less than 15 domestic cases on a daily basis during the past 1 week. The response of that domestic outbreak was mainly a semi-lockdown, we call it stage 3 restriction, implemented throughout Taiwan. The implementation period was from
Excuse me, Professor, Dr. Liu, can you share your PowerPoint? Do you have a PowerPoint you can share? Yes. Sorry, okay. Interruption. Thank you.
Can you see? Okay.
Thank you. Yes, yes. Please go ahead. Thank you.
So here you can see that we have entered stage 3 restriction from mid-May to late July, and we have lifted the restriction on July 27th. We still allow people to work, but we encourage work from home. The main restriction was all schools were closed, and we only allow takeout only, no dining policy since late May. So people's cooperation in Taiwan was pretty good. We see people all over the place wearing masks, and they try to restrict their outdoor activity as much as possible. And people keep reminding people about how to implement those public health measures in a correct way. So on the epi curve, you can see that since mid-May, we have reached the peak in late May, and in June and July, the daily cases number reduced gradually, and recently it's almost usually a digit number on a daily level. There are some key surge out response, including increasing the reporting in census and also PCR testing, and we increased massive rapid testing sites around the island. Also, healthcare response is crucial, so we quickly ask all the major hospitals in Taiwan to mobilize their hospital rooms to accommodate COVID-19 patients, regardless of whether it's public hospital or private hospital. Hospitals were pretty cooperative in this response as well. Also, we enhance our quarantine efficiency by implementing a digital quarantine order system. So those legal quarantine order can be issued electronically to the clients, so they can receive the quarantine order in a real-time fashion. The major objective of our response was to keep our test positive rate as low as possible. The initial goal was to keep the rate lower than 1%, and eventually we set the goal to lower than 0.5%. So you can see here in mid-May, our test positive rate was pretty high as more than 5%. But by implementing massive testing all over the island, we're able to reduce that positive rate all the way to now less than 0.1%. And we still invest in those testing capacity to maintain at least 13,000 to 15,000 tests on a daily basis in order to achieve adequate testing level. One of the major characteristics of this outbreak was it preferentially affects the elderly population. So here you can see our case fatality rate was pretty high among those who are elderly, as high as like 30% in those who are aged above 75 years old. So in this response, some of the new medical care strategies include first, implementing community testing and increasing the laboratory notification efficiency so we can identify cases earlier. And also we issue oximeter monitoring in our quarantine facility, even at home quarantine status, so people can monitor their oxygen level at home or at quarantine rooms. And we also create green pathway for those who are in quarantine facility in low oxygen level to be shipped, to be sent to hospitals in a quick way. Also, a new strategy was to introduce high flow oxygen nasal cannula and the monoclonal antibodies for therapy in hospital for moderate to severe cases with oxygen deficiency. And the monoclonal antibodies also are provided since mid-June in Taiwan for those who have underlying conditions or are elderly, but are at the moment asymptomatic or in mild conditions to prevent them from progressing into moderate or severe conditions. So you can see two major changes during the local outbreak was we quickly set up more than 5,000 quasi-health rooms in those yellow box. So those are not hospital rooms, but they are usually hotel rooms or shelter rooms that are being equipped with healthcare providers and also equipment. So those who have mild diseases can still be accommodated in those quasi-health rooms in a hotel without occupying the hospital rooms during the very strict medical care system. Also, we have also opened almost 1,000 COVID-19 ICU beds specifically for COVID-19 patients. So all these COVID-19 severe cases can be accommodated in a central way without causing hospital infections all over the units. Here is the Delta outbreak in a rural area in southern Taiwan that Professor Chen Xiuxi have mentioned about. By implementing massive quarantine of these villages, more than 600 people were quarantined, and also massive testing in this area, we're able to contain this community outbreak that has been spread within the household or in the neighborhood, in workplace, tea party, taxi, boxes, and hospital contacts. We're pretty worried in the beginning when we realized that Delta has been imported from Peru into Taiwan in such a resource restricted setting. But because of the massive and quick quarantine and testing, we're able to eventually contain that less than 1 month. In terms of vaccination, Taiwanese people used to be pretty hesitant about getting COVID-19 vaccine. But because of the local outbreak, people were much more willing to receive vaccine. Now you can see our vaccination coverage have reached 38% yesterday. And we are hoping that more than 10 million doses will be administered in the next few days. So at the moment, I think we have to keep up the vaccination momentum to increase our protection among the people. Also, a news is that our first domestically manufactured vaccine called Medigen, it's a protein subunit-based vaccine, was granted EUA by Taiwan FDA last month for adults. So we have a domestic tool, vaccination tool now, and we'll begin vaccination with this local vaccine starting on Monday next week. So here's the conclusion. I think the lesson learned are we have to have a quick surge up capacity for those traditional strategies such as test, trace, isolation during such a large outbreak response. And care model have to be reset, that hospitals have to be protected and reserved for those moderate to severe patients. So we can use hotel rooms to accommodate mild or symptomatic cases. Public cooperation was pretty good, and that's the key to our initial success in this semi-lockdown. Challenges are still ahead that we have to keep the momentum to sustain containment of the transmission. People are tired of all these restrictions. So after lifting those restrictions, we are anticipating that there could be a bounce back of the cases, but we'll use our traditional strategies, test, trace, isolation, to suppress those transmission as much as possible, and also keep the momentum and the supply for vaccination. Thank you very much.
Okay, thank you, Dr. Lo's talk. Before the 11 o'clock, we have the few minutes. We may have the 1 or 2 quick question. Okay, any question from our speakers?
A question from the participant.
Yeah.
I do have a question. I do have a question to Professor Chen Xiuxi. I hope he's still there. I think his model is pretty interesting to modeling because it's important for prediction. Can Professor Chen Xiuxi try to establish multi-country, like we have data from Vietnam, and so maybe you can adding modeling for Vietnam's situation. I don't know whether it's possible.
Xiuxi is still there?
He already mentioned and also mentioned about his interest in the question in the chat box that can we develop a cross-country pandemic module? Maybe start putting together data together in a few countries to develop that models. So I think he saw his interest. Yeah.
Okay, perhaps Professor Chen is busy, so until now he didn't respond to our question. So okay, I think it just hand over to the Peter for the next half.
Okay, thank you, Pao Zhong. We have a little bit more than 1 hour for the coming. We have 6 speakers, very prominent speakers. Before I go to the introduce each speakers, and I put a order of the invitation is that Professor Awang Bajia Awang Mohammed from Malaysia will be the first speaker. And the second one will be Dr. Annie Rajmani from Indonesia. And the third one will be Professor Arati Rao from India. And the fourth one will be Professor Chonatong Thanasungang from Thailand. And the fifth one will be Professor Tumbang Tuan from Taipei Medical University, but I guess he is going to talk about Vietnam. And the last one will be speaker from Dr. Jalan Sangkan from Mongolia. Sorry, I have to mention this because I keep people waiting for coming to the speech. And before I also give the floor to Professor Awang, I'd like to mention a supporter for this organization, this forum, particularly Indonesia's Semarang TVKU television. They are already now online for broadcasting this, and also a few institutions like Sichuan Zhangbin Memorial Hospitals, Zhongshan Medical University Hospital, Yanpei Medical Technology University, Hongguang Technology University, as well as my affiliation, Tufts University Medical School, and also Udinese University in Semarang, Indonesia. And finally, the institution, Ho Chi Minh Medical University, Sinmac Hospital, which I'm affiliated now. I appreciate their support, make this program possible. So now without delay, I'd like to introduce 6 speakers, prominent speakers. First one is Professor Awang Bujia Awang Muhammad. He is now independent COVID-19 vaccination advisory committee in Malaysia, and also a prominent, eminent professor, former dean of the School of Public Health, University of Malaya in Malaysia. So now, Professor Muhammad, you are welcome.
Thank you very much. Can I share my slides? There's some other slides which are on
yes,
screen now.
Very much. We can see it now.
No, that's not my slides. Can I share my own slides, please?
Yes, you can. We can see it.
Can you see my slides now?
Certainly.
COVID-19 update. Yeah, all right.
Thank you.
This is an update from Malaysia. Thank you very much for inviting me. I'll be very brief. Malaysia has had several what we call movement control orders, which are basically lockdowns in various forms. Since 18 March last year. So the first one, what we call the movement control order, the MCO 1.0, was from 18 March to about 3rd May, almost 3 months, not quite 3 months. Then there was some easing of restrictions, and then there were localized movement control orders in some states and as well as some localities. So all these have been using 2 acts of parliament, Act 342 and Act 344. And in one particular state, which is quite autonomous, the Sarawak has used its own public health ordinance. The MCO 1.0 worked very well. Cases were suppressed until there were very little community transmission. Unfortunately, MCO 3.0, which was implemented from 12 May. Okay, by the way, can you see my slides?
Yes.
Yes, all right, thank you very much. It's almost total national lockdown from 1st of June. Has not worked very well, and it's taking time to see its effect. The government has put in place what is called the National Recovery Plan in phases. So we've got phase 1 to phase 4. Some states have moved from phase 1 to phase 2. An enhanced movement control order, what do you call it, is in some localities and so on. The government has also put in place several economic stimulus plans. There have been several. There was something called Penjana, which is numbered from 1 to 5. And then there was the Pemerkasa and the Pemulih economic stimulus plan. So they've been in the works for some time, because the MCO has affected all sectors of the economy, and productions and so on have slowed down to a crawl. Malaysia has also gone for vaccines. Late last year, several vaccine agreements were signed. We were late to the COVAX agreement, and it was only signed in November. But Malaysia signed the purchase agreements for the Pfizer-BioNTech vaccine on 24th November, and a supplemental agreement in March. The AstraZeneca Oxford vaccines were also purchased. Sinovac and the Gamaleya Sputnik vaccines were also purchased. And quite recently, I think the CanSino vaccines were purchased. Now, the Johnson & Johnson and Sinopharm vaccines have been approved for emergency use quite recently, last month. So we've got a number of vaccines which have been approved for use in Malaysia, and agreements have been signed, and supplies have been assured for about 130% of the entire population. So as you know, these are all mixed bags of vaccines. The largest number is the Pfizer-BioNTech, which should cover around 60 to 70% of the population. So for the vaccine rollouts, there's the committee called the JKJAV, under which are several committees. And then to roll out the actual vaccination program itself, a task force was formed. Now, I happen to head an independent COVID-19 vaccination advisory committee, which are mainly made up of academics from various universities and so on. So we started our vaccination program on 24th of February and has been proceeding. There's a public-private partnership going on now. There are mobile vaccination buses. There are a few things that we have to take note. The first wave was just imported cases in Malaysia. The second wave was last year, which resulted in the first movement control order and was handled quite well. However, there are a lot of lessons from the second wave were not really heeded. So the pandemic is not yet over, and the third wave is proving to be more daunting. But we hope that the national COVID-19 immunization program will help us find a way out of this pandemic. Currently, the vaccination rate is between 400,000 to 500,000 doses per day. So we hope that by the end of October, we will be able to vaccinate around 80% of the entire population, which will probably include some children, because children form around 28% of the population. So we have not approved the vaccination for children under 12, but between 12 to 17, they've already been approved for the Pfizer vaccine. So what has the vaccination done? The vaccination has shown some effect in some states which have vaccinated more than 50% of its population with the second dose, such as the largest state in Sarawak, where the number of severe cases have dropped quite dramatically. The number of mild cases have remained quite high, but the number of severe cases have dropped. So their ICU beds are being emptied now. So it's quite all right. However, in the Greater Klang Valley, which is where the city of Kuala Lumpur is and the satellite towns and so on, that's about a population of about 7 or 8 million. We are still struggling with the pandemic here because of the Delta variant, and we hope that by the end of October, I think the vaccination will find us a way out. So that's all from me. Very short. Thank you very much. Let me just unshare these slides.
Thank you so much, Professor Awang. Very interesting and very promising regarding all your effort. I also like to acknowledge it of your colleague, Ting Ting Su. She used to work in but now she moved to another university in Kuala Lumpur. And thank you that all this beautiful presentation. So now may I introduce the next speaker, Professor Annie Rajmani. She used to she just have her deanship from the Faculty of Health Sciences from University of Dianuswantoro in Semarang, Indonesia. I knew her for many years. I'm very happy to see her present this coming presentation. So Annie, are you ready? I can see your presentation ready. You may go ahead, Annie.
Okay, thank you. Something like this. Sorry. Okay, I want to thank you for this opportunity to talking about COVID-19 Indonesian. We will talk about how Indonesia handle and control in COVID-19. I will briefly discuss about 4 topics. The first one, Indonesia situation, and the second is COVID-19 control program. And the third is infodemics, maybe is special Indonesia, and the last one is challenge. Actually, the first one is I want to talk how Indonesia have a big challenge because we have more than 270 million population, and we have more than 70,000 islands. So in this pandemic, we have many challenges and obstacles to handle this pandemic. But distribution is more than 50% is in the Java. So the Java is the center for the controlling the spreading of COVID-19. I think this is the timeline, the progress that we have experienced. Right now, we still have many cases in Indonesia. Totally, we have more than 3 million confirmed active cases. And actually, we have a very big target in vaccination, more than 200 million vaccine. So it's maybe very high compared to the other country. Actually, now we still face COVID-19 second wave because we have a tradition in Muslim Eid celebration called Mudik, that movement people to meet parents and family from original place. So it's make a second wave of COVID-19. Actually, our government is still challenged to control the second wave. If you see, we have eight celebration in 13 May, and after this day, we have peak cases. Many cases happen in recently. We have three variant of COVID-19, all of Alpha, Beta, and also recently is Delta that make a second wave of COVID. The program that our government try to apply is the enforcement of restriction of community activities. Indonesia never apply a lockdown because we still afraid that we apply lockdown, we do not have like will have a difficulty in economics. So we like try to restrict in some activities. This is our government strategy. So many names change time by time, like large scale social restriction until right now is we call PPKM level 1, 2, 3, 4. Maybe there is one question: what is level 1, 2, 3, 4? This is our government might give an indicator how to give a level in the restriction. Is depend on the indicator in every area. I mean, is one city have an indicator like have hospitalized in 5 until 10, so the government put in the level 2. So every time the regulation is changed to adopt this level. Actually, in the compliance level in health protocol in Indonesia is widely high, but we have another problem. Is we do not have like a strict sanction for violator. We just like make a approach to the people to make them make a social responsibility, something like that. And maybe they just put them in the cemetery to pray that they already violate the health protocol. So maybe there is not a regulation like in Taiwan. There is a 1,000 NTD to fine to people that violate. So it's different. We have many type of vaccine that already apply because we have many people that should get vaccine. So almost of the type vaccine we agree in Indonesia. Like we still have a get coverage vaccine only 13%. So it's still a long way to get the target. We 200 more than 200 million people. We apply many applications to try to control people activities, move to another city. This is application for traveling in the airplane, and this is application for people in every day. That in this application, people can store their vaccination card and vaccination registry, and they can detect the status area of their area. This is the online registration for vaccine. And the special cases in Indonesia is infodemic because we have so many information, misinformation and disinformation in the community, and it make a some people rejected about vaccine. More than 30% rejected vaccine because the infodemic. So many hoax in the WhatsApp, in the Facebook, something like that. So it's make our government very difficult to control. This is the picture that our healthcare staff is very exhausted handle the second wave of vaccine. So the challenge in Indonesia is, the first is the low digital health literacy. Indonesia, many people use a digital device, but they just easily to share misinformation. So it's make an infodemic, because some is because also like education. And we also have limited health practitioners compared to the population. So we have slow treaty, testing, tracing, and treatment. So we also have a limited vaccination process. So we slow get herd immunity, and it's still very challenging to Indonesia to handle this pandemic. Thank you. I'm sorry if there is something that you don't understand, and maybe we can discuss later. Thank you.
Thank you, Annie. Very interesting and very concise summary of what's ongoing. Apparently, you are doing pretty well. Annie also now is besides the dean, but also the director of the ACLA Indonesia office. And we appreciate very much your good continuous support to ACLA and also the television program in Indonesia. And I certainly like to appreciate Sri of your institution. She also Assistant Secretary General of the ACLA. Thank you so much. Now, if I may invite the next speaker, Professor Arati Rao from Manipur Academy of Higher Education in Indonesia. In India, I'm sorry. We are hoping, we are planning for the 2021 or maybe 2022, the 8th ACLA conference. I know we still have something to do, but hopefully we will have that very soon. Thank you, Arati. You are on board now. Welcome. You may open up the microphone. Microphone, please.
Can you hear me? Can you hear me?
Yes.
Yes.
You can hear me? Yes. Yes.
Good.
Thank you very much. Good. Thank you, Professor Peter Chang, for your kind introduction. I bring greetings to each one of you from Prasanna School of Public Health, Manipal Academy of Higher Education, Manipal in South India. The topic of the webinar is highly pertinent in the present day circumstances, and it is representative of our intentions to join hands together to fight unitedly to curb the pandemic. I'm sorry I don't have the slides, but I have penned a few thoughts for this occasion to share my views and opinions on the current COVID-19 surge in India. India's current COVID-19 surge is an unprecedented public health crisis. Currently, we have a total cases of close to 32 million, with 0.4 million deaths and daily active cases close to 42,000. India is currently the second most affected country in the world. It is worth mentioning that the current surge in the pandemic situation of India can be attributed to different circulating variants of SARS-CoV-2, with a special mention of the Delta variant of concern and now the Delta Plus. With a population of 1.3 billion, India took up this challenge to address the pandemic situation, to execute phase-wise lockdown, unlock, and partial lockdown activities, which has been appreciated by the World Health Organization as an outstanding strategy to curb the outbreak. Various pharmacological strategies for the prevention of COVID-19 through contact tracing, screening, quarantine, and isolation have been emphasized. There were a total of 11 phases of unlock in the country since June last year, with standard operating guidelines laid down for various public places, treatment facilities, international and domestic travel, and civilian movements. In this time, informatics centers in Delhi under the Ministry of Electronics and Information Technology developed a mobile app Arogya Setu to identify the corona clusters in the country and received the appreciation from the World Health Organization as well. Meanwhile, zoning of the districts was done across the country based on the attack rates, which would help in the surveillance and stricter enforcement of anti-COVID measures. Given the regional diversity in Indian cultures, assessment of the impact and severity in the daily life was conducted as diverse cultures has different priorities for their daily life activities, and decentralization was announced for the standard operating guidelines. Age and risk-wise vaccination plan was prepared to make the vaccines available to the population, and the vaccines were rolled out. This year, on the 11th of April 2021 alone, there was a case surge of 169,000 people were affected with COVID-19. The cases mount to nearly 400,000 cases on a single day in May 2021. In the wake of this sudden surge, Unlock Phase 11 was announced till the end of April, which was continued till May and June. It had the same protocols as announced earlier, but additionally, test, track, treat protocol also need to be strictly followed. This protocol included aggressive testing to detect early cases of COVID-19, timely isolation of positive cases, contact tracing, and also demarcation of the containment zones. Also, the reverse transcription quantitative real-time PCR, RT-qPCR test was instructed to increase to the prescribed level of 70% or more. The two vaccines rolled out were Covishield from AstraZeneca and Covaxin from Bharat Biotech with 2 recommended doses, firstly prioritizing the at-risk primarily, followed by general population, young adults, and finally the pregnant women. The Sputnik vaccine has entered the Indian market as well. Demand for vaccination rose sharply with the onset of the second wave, with the supplies difficult to match the requirements. As on July end last month, 3.5% of the Indian population have been completely vaccinated, and only 16.2% have been partially vaccinated. And as on today, the vaccination coverage stands around 20%, and the vaccine supply were to last only till the end of July 2021. Although the second wave is subsiding, it has left the country devastated in its wake. Religious and mass gatherings have been allowed, lax behavior of the people towards following COVID-appropriate norms. The vaccination drive is on the wane as well, and the threat of a third wave looms large. In the words of Maurice Schwartz, death is a great equalizer. But I would say that was prior to the pandemic, because COVID-19 has equalized those who are alive. Because I see similar issues across the nations, irrespective of the denominators. It's a wake-up call for the global community to join hands with each other to win the pandemic situation. India looks forward. Hello, am I audible?
Go ahead.
Am I audible?
Go ahead.
Yeah. So India looks forward for international help in areas like expanding the healthcare capacity to save lives of our citizens. India needs oxygen concentrators, ventilators, medications, high-quality protective equipment, and SARS-CoV-2. Rapid diagnostic tests, kits, international must support access to COVID vaccine in India, help India address the vaccine shortage. Scaling up of lab testing in the form of rapid diagnostic tests and innovative methods like home-based and outreach vans. Technical assistance and training for the people on ground to help the weary health workforce. Prevent the COVID-19 surge to become a regional disaster. Travel restrictions and mandatory quarantine, upscaling the surveillance measures. So facing this severe global crisis of COVID-19, solidarity, transparency, and communication makes great sense in this process. Online forums and meetings have great advantage due to its features of timely accessibility, cost effectiveness, and contactless forums. These forums also should bring to table opportunities for activities related to health literacy promotion and discuss the role of health literacy in preventing future such disasters. Thank you very much for your patient listening.
Thank you, Arati. I appreciate this very important presentation because we look for your experience in India. I also like to appreciate Professor Hammer Brown. He cannot be with us. I guess he's in Germany. Actually, he's the most important person to come to Taipei 10 years ago. That we started the Asian Health Literacy Association. Please send my regard to Professor Hammer Brown. Thank you so much. Now, may I invite the next speaker, very important speaker, professor, but also the former dean of Dr. Chanantong Thanasungang from Mahidol University. She has been very, very active in Asian and global public health. And we are very honored to invite her to make the presentation. Professor Siti, you are welcome. You may open up microphone, please.
Sawadee everybody. Greeting from Thailand, but we have to work harder in order to get the COVID-19 in control. So let me share my slide.
Yes.
What I'm going to share with you is the experience that we need to find ways to cope with the situation, because the problem in our country that affect COVID-19 strongly. I think you follow the news that even though we have the COVID-19, but people are still fighting political situation. So it add on to the burden of public health issues. The second issue is about the technological. We hope that we can do the digital like in Taiwan, but people in Thailand has the diverse learnings and digital literacy. So we cannot utilize technology all over. So we still keep two models. And the health system on the first round, I think we all think that Thailand has a very good public health structure, but because of the different variants of the virus, so we are now hit hardly. The hypothesis that we are taken had to change. We in the first round, we think that we can eliminate it, and we have developed the economic recovery plan. Till now, we think we have to change it, how to live safely with the virus, but people still have different reaction to it. People still have rumors. So infodemic hit us hardly also. So because of the political problems with this vaccine management, we come up with the issues that we cannot depend upon the medical vaccine because of the value of the people as well. They think that they have been vaccinated, so they can do anything. And that's why we fall into the health literacy vaccine. The problem with the overstretched healthcare system had made us to come up with another model with the home isolation or community isolation. And with that in mind, you know, the experience is similar to other countries, but if we review our achievement, we realize that the surveillance, the case management, and contact tracing and all those have been helped by the community people with the village health
Professor Siti, wait a second. We don't see you move on the slide. Maybe you can open up, click the down button. There was a box. Then it will follow your order.
Down bottom.
Yeah.
Let me see. Where is it?
On the bottom from right, there was a box next to laboratory control. If you open up, then the PowerPoint will follow you.
Okay. Follow me now? Is it?
Not yet.
Oh, it's on my screen. Is okay. Okay.
Or maybe I try from my side, you recheck.
Okay.
You get, and let me see, I can help.
Yeah, I'm on the, because all these are Chinese, the character that I can't read. Sorry for that.
Yeah, that's fine now.
You see that?
Yeah, you have that in control. Yes, go ahead.
From my presentation, right? All right. Now I'm reviewing the situation and point out that the country has faced a lot of problems in the communication and coordination. Joint Information Center. It is quite top down, so the people cannot follow the strategies or announcement from the government. So they revised the plan again to be decentralized to the province and come up with a strong emphasis on the communication, mental health, and vaccine. Because of this, they use the color. So people now are familiar with the green, yellow, and red for whatever situation in the COVID. Mental health still very bad because people do not follow the regulation and they feel sad of all the news that overwhelming to them. So the Faculty of Public Health is located in the new area, which is called Yoti Medical Innovation District. Okay, and this is a symbol that represents our organization that combine the University of Mahidol and also the Ministry of Public Health, Ministry of Higher Education. And we promote innovation. So digital innovation startup people are here with us. Therefore, we come up with two models, the health literacy because of the communication problems, and health and wealth public-private partnership, so that we can do some of the movement along with the photonovela approach of the health literacy. We come up with the area base in our location of the district. And we had the Insight Human Capital and the professionals working together, come up with every settings in the community, in the two districts. And because of all this, we able to see the lower infected rate, but we cannot control the infodemic. So we approach mosque and Buddhist temple to be a center that reach out for the homeless people and giving them, the equipments, how to control. However, the people still need to join because they feel sad and they feel uncontrolled, helpless situation. So we use the concept of Peer for Progress network that we achieved strongly, highly achieved in the district level. We are using this, but because we need to protect our team not to get infected. So the digital AI home visit, using the Zoom meeting to upgrading them and live reporting system. All of this had put together so that people in the community with the low income people will be able to join us. So we have the twice a week of learning together and sharing the case conference. For the health and wealth, because of the new normal, we think that how can we do the social well-being? And this is the EU proposed model, which in Thailand, we think the health system plus the community system should be the way to go. And because we had a problem economically with the real estate people, the land developer people, the construction site. So we join hand with all of these company, private, public partnership to come up with not only on the site using the health literacy, but also come up with a community isolation unit. So every location where there is a big company for the land developer, the construction sites, we do the bubble approach model. And this is started now. We also realized that the migrant workers in the construction business are coming from the neighboring countries, so they cannot read the Thai character. That's why we come up with the pictorial checklist and assigning them to work together with the family and peers. We started to see that Phuket had announced that they have the opened up tourist area, but the safety and health accreditation has also working side by side so that we can pick up the 3T, the testing, tracking, and treatment should be available. We also adjust the treatment in the home isolation by using our herb endographic. So people feel like they have done something and they have received some support medically and socially. And these are the model that we are ongoing right now. Because of all the research from Health Literacy research has shown that people in Thailand who had gone to the good information system have a better decision making, and they are free from infected. And this is our big questions that we have also want to conduct research as well. So thank you very much. These are all from updated model in Thailand. Thank you.
Thank you so much, Siti. It's a beautiful presentation that we help us learn a lot about your effort. Siti is one of the founder member of the AHLA and still a champion for health literacy in Thailand. So I appreciate your good effort. Now I would like to invite another fellow. We used to work together for many years in Taipei Medical University, Professor Tumbang Tuan. Now, I know Taiwan has succumbed him from Vietnam for many years. Luckily, he didn't forget his good effort in Vietnam. I know that in the last 1 year, he published more than 20 articles on health literacy, on nutrition, on COVID. I'm very pleased to invite Tuan to come to this presentation. And likely you're going to cover at least Taiwan and Vietnam. Tuan, you are very welcome.
Thank you very much, Professor Peter Chang and Professor Chan and all the organizers. I'm very glad to share with all of you about a perspective, a small on my lens about the COVID-19 experience in Vietnam. Certainly, there's 5 professors already share some experience in Taiwan, so I just share some in Vietnam in some perspective, right? And I would like to start with this one. When the whole world is fighting with the COVID-19 badly, starts from early of the 2020s, and in Vietnam, you can see over here, we still somehow we're still fighting COVID seriously, but we also enjoy our peace for more than a year, just like Taiwan. And start from April, end of April, early of the May, that the case of COVID-19 in Vietnam is rising, and we are still on the peak now. We haven't seen any cruise for the down slope, and the situation now, we have about 240,000 cases around the countries, right? So this is some tactics that I also asked a question on the ResearchGate, and so that I received so many comments and also some ideas and also suggestions. So this is some tactics from early state. I think this one is from the wave 1 and wave 2 that we use. So in different state, we use different measure, different strategy, and involve so many measures over here, including the government, lockdowns, national movement restrictions, public health measures, and social distancing. And this is in April last year and moved to the July, the second wave, I guess. So we also have the key weapon to fight COVID-19, including the rapid response and also some specific F1 to F5 chasing system, and also especially for the public education. We emphasize public education very much last year and until now. That we also published some lessons for the health education using the media. So we our audio and video promoting materials have get attention from many international organizations, and we are very successful in that when people listen to that audio or videos, they likely to adhere to the preventive measures. So you will see over here more than 90% of the people watching those videos or listen to the song that they adhere to the hand washing and also face mask wearings, and also social distancing, and also no discriminations or stigma against those people have infected or people isolated, and also awareness of the fake news. So those are very important that we were successful to fight the COVID-19. The government have some policy response to the COVID-19, which is this one was published earlier this year's end of the last year's. That we have 8 measures over here to summarize. The first one is about outbreak announcement and steering document, medical measures, school blockade, emergency response, border and entry control measures, social isolation and nationwide social isolation measures, financial support, of course, this one is in many countries also used, and also other measures, right? For example, if you need to get a punishment if you don't follow, but not the main, so just a slight measure that we use in Vietnam last year, end of the last year's, right? So this is the wave 3 that in the end of the years 2020 and early of the 2021 that we use to control the pandemic in Vietnam. The first one is about early preparedness and contact tracing, isolation and testing, timely border closures, physical distancing, and community adherence. Right, so move to the 4th COVID-19 wave, start from the end of the April until now, is still ongoing. That we have some, wait for some measures, for example, isolation and testing. Of course, we also use all of the other measures to control the pandemic. One important is for the community adherence. So we send the message to any organization, individuals, so through the social media and many other channels, with the message how to safely coexist with the COVID-19. So we call it the 5K. 5Ks, it means the face mask wearing, disinfection, no gatherings, and distancing, and so health declarations. And of course, the most important strategies now were emphasized throughout the country, and so I learned that many countries and so focus on vaccine. So the governors, the government chief also emphasized the vaccine is important at the moment. And how we can do that? So there's we have called it the vaccine diplomacies. This one was initiated and also ordered by the government chief, the prime minister, and also deputy prime minister. That we collaborate with the COVAX facility and many other countries throughout the world. And in July, we also the government also asked Ministry of Health to establish national vaccine institutes, and there's one domestic products for the COVID-19 vaccine in Vietnam. We call it NanoCovax, and were approved by the Ministry of Health that this will go through the phase 3 clinical trials, and now they recruit about 13,000 participants to join, and we expect that to have this vaccine by end of the 2021. And with that, the government emphasized triangles strategies to receive the herd immunity for the Vietnamese population by purchasing vaccine as soon as possible, accelerating research and transfer the production technologies, and also getting people freely vaccinated in a bid to achieve the herd immunity in early 2022. Can you still see my slide?
Yes.
Yeah. Okay, thank you. So right now, we received about 12 million doses of vaccine, and we deliver to about 11% of the total population, and more than 1% is fully vaccinated. Very low, but we have planned to achieve our herd immunity in earlier 2022. So with that, I have the last message is about for the national cooperation, international cooperation, that if you're already vaccinated, I mean your countries, and don't try to get the booster vaccination first, but you share the vaccine to other countries. And just like Professor Wang mentioned, that we are not safe if, and also Professor Chan also mentioned that we are not safe if we are with all of us not safe. So share the vaccines, and with that, I hope that we can fight COVID-19 together and have a very success very soon in the very near future. So thank you very much.
Thank you. Xin cảm ơn Tuấn for a beautiful presentation, and also it's important that we still work for Vietnamese to overcome this crisis. Now I have the last speaker on the list. She is joining us the last minute, Dr. Jagasakan Bada, on behalf of the New Public Health Association Mongolia. After the last presentation, we will have a few question and answer, and I already enrolled a few questions. Please remain with us. Even we will go a little bit beyond the time, but please remain with us. So now, Professor, please, you are welcome.
Thank you very much, President Professor Pete Chan. And first of all of you, and I would like
to open the video also?
Okay, let me.
Just opens slideshow on the
slide on the
right corner,
okay.
right down button there. You see the cup.
And how can I find? I couldn't find into all in Chinese language. I don't know how to open my video.
There was a sound control on the bottom left.
Bottom
next
left.
to that will be the video. If you just click on the video, maybe you will.
Button. You can press F5 on your keyboard if you have.
Okay. Did you find me?
Yeah.
All right, good.
And
thank you. You're welcome.
Where is my slides? Might be lost, or do you? These are my slides on the screen.
No problem.
No problem. And most of all of you, I would like to great congratulations to all presenters in the morning. In behalf of the Dr. Dolam Sureng and the leader of Alpha Mongolia, she is the president of the New Public Health Association. I wanted to share with you right now, it's not a research report, and just I wanted to share with you just the brief insights or latest working conducted by the New Public Health Association. And let me share first how about the situation of COVID-19 cases in vaccine rollout in Mongolia. And if I open the link, we will check the situation, today's situation in Mongolia. You know, Mongolia is a very small country, population is very small, and territory is very big, but might be the cases made it's very small, but country is has a very small population. The confirmed cases of the COVID to date are 178,000. In this 869 today. In the vaccine rollout, Mongolia's quick scale up, and 61% of population fully vaccinated, and 67% given first doses or to date, August 13. You can see in the Mongolia's in the vaccine rollout, Mongolia 1, 2, 3, fourth country of all population, the main population already vaccinated. It's just information. And next slide, I would like to share you about the New Public Health Association training on interpersonal communication for immunization during the COVID-19 outbreaks in our country. Indeed, was organized in April and May 2021. Total 925 frontline healthcare workers participated in the training from the 9 districts in Ulaanbaatar in the 21 IMX. The training was supported by Ministry of Health, UNICEF, under the Gavi Post-Transition Engagement Project. New Public Health Association work very close with the Ministry of Health and UN agencies, WHO, UNICEF, and World Bank during the COVID-19. And they requested us to organize and facilitate training of frontline healthcare workers during the COVID-19 outbreaks. Rationale. Vaccine hesitancy research conducted by New Public Health Association was shown that quality of the interaction between the health workers and the parents is the key factor to ensuring completion of the vaccination schedule. Frontline health workers are most influential sources of the information in vaccine behavior, and they are a crucial bridge between the communities and their health services. With this role, practicing good interpersonal communication is the key improving immunization coverage, key action. That's why Ministry of Health requested us to organize this training. And I would like to share, save the time, would like to, within the 3 minutes, as I promise you. Objective was upgrade the knowledge of the interpersonal communication, principles, perspective in various problem-solving contexts. And the second objective was to improve understanding and immunization of vaccines among the parents, among the healthcare workers. And third one, and encourage ability to interpret, understanding, and acquire effective interpersonal communication skill. In the training methods, we have used in traditional knowledge-based lectures, PowerPoint slides, and plus we have used in participatory learning tool with the question and answer and discussion. And the last one is very important. We have used the sharing the peers challenges in how to find solution. And training activities in outwards. Training conducted online and 10 sessions is approved agenda by Minister of Health in the schedule by the Minister of Health. And the pre-post and training assessment done, participants obtained the information in the interpersonal communication for immunization, increases their knowledge in their personal communication that determined by the COPA humanitarian to response. And that's all my brief sharing insights. And thank you very much for your attention. I have to leave in the time for others. Thank you.
Thank you. Well, thank you for Mongolia AHLA office and your consultancy. Now we have a few last minutes, but we have a few burning questions coming from participants and the audience. In order to make this possible, better communication, I would like to, I don't know whether Professor Wang Sang Hole is on the board. He has the first question. Is Professor Wang Sang Hole? If not, if Professor Wang Sang Hole is not here, he has a first question, and let me read the question. He said, what role for ASEAN in terms of regional cooperation against COVID-19 and any value added on? I'm wondering, we have quite a few speakers from ASEAN countries. Maybe I can invite Awang, Professor Awang, to
Sure, thank you,
address
Professor
this
Chang.
question.
Yeah.
Thank you.
Yeah, I always thought that there is a lack of regional coordination among the ASEAN countries when the pandemic started, because it is a pandemic. So there is no one country which will remain safe unless all the countries around ASEAN work together to make sure that they are safe. So the first thing I think ASEAN should do is set up a proper working level regional network to coordinate the data sharing as well as the scientific know-how, and perhaps where there are bordering countries, perhaps even testing facilities, especially when testing facilities are really under great strain in one country. That's the first thing which I thought should have happened, but it didn't really happen. We have this broad, high-level interministerial network, which doesn't really work because that's too high level. We need a level at the working or technical committee levels to share data and scientific know-how. Secondly, I think, as you know, because ASEAN, the economies are quite tightly linked to one another in the sense that there's a lot of migration between ASEAN countries, especially for people. And this is where variants like Delta can spread rapidly from, say, Malaysia to Thailand. Very unfortunate because our border is very porous, and people migrate across borders like that. Philippines to Malaysia also is rather porous, and they're very close by. You know, it's just a matter of driving across the border or a short boat ride. So border controls need to be really coordinated. If they are not coordinated, then the pandemic will persist because you have different policies across different borders. Thirdly, I think there are varying capacities for production of vaccines within ASEAN. Some countries have the capacity to manufacture more vaccines than others. And of course, vaccine nationalism will come into play because, of course, we understand that governments will have to prioritize their own populations when it comes to vaccination. But certainly when there is a need, I think perhaps some help between countries where there is a severe outbreak, for example, then it should be better coordinated. So just the 3 points from me. Thank you very much.
Professor Siti from Thailand, you're also a very important player in ASEAN. Would you like to add in some comment regarding the question? Yes, thank you.
Yes, I'm checking now because the ASEAN Training Center for Social Work and Social Welfare, the office located in Thailand, and they had just recently organized a training for the social work network in ASEAN. I'm one of the speakers there. So there are movement via the online that I know of.
Yeah, thank you so much for the feedback. May I have ask the second question on behalf of the audience regarding they are asking how to manage the vaccine hesitance in Taiwan. I think this is the same question to everybody, but they ask in Taiwan. I don't know whether we have Professor Zhang or Professor Meixiang Ho would like to address the question, to respond to the question. How do you manage the vaccine hesitancy in Taiwan?
Basically, here, this is Meixiang Ho speaking.
Okay, Dr. Ho, please.
All right, I open my video. All right. Unfortunately, in Taiwan, vaccine hesitancy is not intrinsic to our culture. There have been a few scholars who really advocate not to vaccinate, but that was on the use of flu vaccine, not the childhood vaccine. So as a whole, our population accept vaccination quite well. But we do have a, should I say something about political problem, political splitness in our country? Yeah, I should say that because it is so obvious in our country. The vaccine issue quickly becomes a political issue. So basically, our government did not, the vaccine did not come in time to supply, to vaccinate the people, and it was our government's, the government's fault. So the opposition party, which is, have a lot of, just, it's always, whatever the small issue becomes a political issue. And also our domestically produced a vaccine that, of course, we did have a little time lag in terms of conducting phase 3 trial. So we were using something they call immunobridging. It may not be a proper term, but basically just to look at the neutralization antibody and standardize it, and taking the already approved, already received EUA vaccine internationally and compare the neutralization titer with it. And we set a level quite high for that. And then we approved a EUA for one vaccine in our country. And then again, this vaccine became a political issue. So it's, just it's everything. It just, that's what's in Taiwan. So what we have to deal with it is a lot of this type of problems. So we, the academician or the scientist, do our best to, fill the media pages with our scientific views, not allow the political opinions to just, overwhelm everything. So that's the fortunate part. Unfortunately, I don't have something to share with you about our vaccine hesitancy. Of course, there's a small fraction of the people who are very concerned about the side effect or the adverse effect of this new vaccine, the gene-based vaccine. So, and the concern, in my view, is somewhat real. So we obviously say, well, it's more beneficial. You weigh the benefit and the loss of not vaccinating. No, you say this kind of thing. So people are really scared of this new vaccine, and I do believe there's a scientific basis to it, because they do have medical problems such as hypertension and such as previous problems with thrombosis, etc., or some autoimmune diseases that, sort of somewhat of a little bit against of using this gene-based vaccine. So for these people, of course, they would feel much more comfortable with the protein-based vaccine. So this is our native problem of our nationally produced vaccine, which is a protein-based vaccine. And a lot of time people perceive it as safer. I believe indeed it is safer. So we are right now at the middle of it. This is what I can share with you.
Right, thank you, Dr. He. Very interesting, ongoing. I think Taiwan still has to do that more to make it. But my feedback is a little bit is because vaccination usually start from children, babies. right? We don't do adult vaccination very much. And even we have in Taiwan, you have a flu vaccination, only 35% of the adult population are covered. Now you asking 80, 70% of adults to involve in the fight. You know, people don't fight, right? People have an easy life. You don't ask everybody to go to military to fight, usually. So adult people are not used to do such a fight. We used to call 30%, now you call 70%. These people are certainly have big problem to come to so-called herd immunity. They would like to join because it is not, I think it's not in culture everybody. No country in the world has such huge coverage of vaccination, right?
Peter, let me respond to it quickly. Peter, I think right now there is a misconception of what a herd immunity is. Of course, traditionally we believe the overall coverage of certain percentage, then we achieve the herd immunity and the transmission will slow down and will eventually come to a halt. But unfortunately, right now, the whole world is dealing with the Delta virus. And I believe at this moment, it's very difficult to define herd immunity. I see what's in England. I can tell you how much they have vaccinated and what is the focus of it. In England, I looked at their vaccination coverage rate of 2 doses above people over 50 is way more than 90%, way more than 90%. So that's what's important. That's why they were able to relax and lift their lockdown, etc. So they have totally lifted all the restrictions, social restrictions. So and their cases are indeed coming down, but they do have a seropositive rate of 93%. This was surveyed at the end of June, 93%. And when they break down the ages, it was seen that the younger ages, their seropositive rate are way higher than their vaccination rate. That means they acquire their antibody from natural infection. So modeling the England, of course, they have gone through 3 waves, originally last March and of Wuhan, and then fall to early part of the 2020, that was Alpha, the England variant, and now the middle of 2021, that's Delta. So they have, of course, gone through extensive community transmission, but they do acquire quite high seroprevalence. So I think in our country, what we aim to cover at this moment, we are not talking about it because the elderly are scared. So we allow them to rest a little bit, and this is summer anyway. So, but we do have to come back, convince all of them, preferably, of course, at least people over 65, but preferably all of them over 50 are covered as much as we can, and hopefully, like England, more than 94%, 95% of the 2 doses vaccine coverage rate. So that means when you cover all the high risk group for severe diseases, you just allow the virus to spread. And occasionally you see a few more severe cases in the young people, but there's a lot of transmission, but very few severe cases and nearly no death. So that's the experience. So it's not the overall coverage, it's the coverage of high risk groups. That's what's important.
Can I add to that, Peter?
Yes, Awang, please.
Yeah. That has actually been our experience in Malaysia. The vaccination coverage is actually very uneven in Malaysia. Sarawak is the biggest state in Malaysia, but with very small population. It's only about 3 million, that state, but it has an area of 124,000 square kilometers. So, but it pushed forward for vaccinating its people very quickly. So we have seen that the number of cases have remained quite high, actually in Sarawak, but the number of severe cases have dropped dramatically because they've covered practically all the vulnerable people, the elderly, the ones with comorbidities and so on. So what we are seeing now are infections among probably younger ones in that state, and which are relatively mild. So we have seen the effect happen in Malaysia, but we only saw a really dramatic fall in that when that state reached about 50% coverage of its population. Of course, there's a lag period between the actual coverage and the immunity. So it is very promising in the sense that you need to ramp it up. Other states in Malaysia have far less coverage, including the central region. The central region, unfortunately, has a very high migrant population, which is a very unfortunate thing because many of them are undocumented. So we don't really know the denominator, who they are, and they're continuing to spread this disease, we believe. And many of those who were brought in dead are among migrant population, so they did not know that they had the infection. So the message from it is herd immunity is, I think, going to be a very elusive goal because herd immunity depends very much on transmission protection. And we know they might not work with some variants like the Delta variant. So we are depending very much on direct protection now to reduce the severity of the illness. So I guess as the pandemic evolves, direct protection perhaps will become more important than when the transmission protection. So we probably will need to vaccinate just about everybody, including children, eventually, I think. Yeah, thank you.
I know that it's not only biotechnology, but it's a politics. It's a politics because the question regarding to the vaccine has it. I remember a German doctor, Rudolf Virchow, he said that healthcare is politics. So I don't think we can forget about the lessons that because when we develop all these to fight with the virus, we have to deal with politics. It's for sure we have to deal with politics. The better politics can serve, I think we will have a better management of the crisis. But I don't see we have enough time to deal with that. I have my good fellow mentor, Professor Shi, still on board. I would like to invite him to give some comment and invite all the speakers to give the last minutes. So Professor Shi, are you with us? Can you open the microphone?
While waiting for Professor Shi.
Yeah.
Before that, Peter, I'll add my comments.
Yes, please.
I think we are facing in Asia currently is a vaccine hunger and choice problems. It's not literacy problems, hesitancy problems. So if we want to do this, we have to input into our literacy program, talking about because we are using 3 different platforms, and people are worried about this effectiveness and side effects. And so we have to provide science-based information for our society to use. So that's very different from a country with a lot of vaccines and they have hesitancy. That's what my view is. So the other one is this impact by social media. That you have to compete with unfounded claims in social media that are flowing around in our regions. I do have an Indonesian maid in our home, and she got all this information from her social media, and she was reluctant to get vaccinated at the beginning. And after my discussion with her and make sure the vaccine we're using in Taiwan is safe, and she agreed to use it. So you can see how powerful social medias are cutting through all the countries. So we have to do this as soon as possible to give information, correct information to all the migrant workers in different countries. I think that's much needed. So that's my addition to this vaccine program. Okay, thank you.
Thank you. Thank you very much. Professor Shi, please.
Yes, I'm going to leave now, but before I leave, I will say two things. Number one, I appreciate Peter and Dr. Chen Baozhong and every wonderful speaker to make this forum successfully. I learned a lot, number one. Number two, so far we have a lot of keywords: masking, social distance, vaccine, a lot, every day, repeatedly. Now I would like mention to one word, IDEA, idea. That stands for intention to design environment appropriately. We have virus, then we become the violent everywhere. So ecology system is terribly important. How we build the ecology system coincident with virus, or how the ecology system to inoculate virus. Nobody talking about that. Please, everybody think about, especially for ecology system people and also the virologists, to think about ecology system and viruses. So again, I thank you everybody, and think about ecology system. How? Because now the emerging infection become very common. So how we should live in set virology system, ecology system to inoculate what called incidence of the virus. That's my comment. Thank you.
Thank you. Same comment, Professor Shi. Don't you want to respond to that, for a comment? Don't, please.
Yeah, I'm very impressed by the comment from Professor Shi that we should establish the ecosystem to have enough vaccines, and also we can beat against the COVID-19. And also, I would like to mention a little bit about the question about the vaccine hesitancy that right now I'm conducting the study and doing literature review quite well about the vaccine hesitancies. It's a worldwide problem, and in the average, the worldwide average is about 70% or more have hesitancies, one thing is that the employers have influence very much on their employee perception about COVID-19 vaccine. And we also found that health literacy also very important, that we submit one manuscript related to that. And health literacy play very important role that if we can add the health literacy to own population, and also add the health literacy to the employer, I mean the employers, then they change their perception and also influence to their employee and also the communities and also the household. So with that, I would like to close my talk. Thank you very much for everyone.
Well, thank you so much. Because time, I would finish my chairmanship, and I appreciate all the speakers and all the supporters, and also Taiwan Association for Public Health. May I give the microphone back to Professor Chen, that he would have the last word. And yeah, Professor Chen, you have the microphone.
Okay. Thank you. I think I I heard a lot of the information come from the different country, and we may share the country experience with us, because nowadays the COVID-19 epidemic in different stage of in different countries, but we can learn each other. Maybe in this time Taiwan is okay. Maybe we don't know the next time, because we are facing the very different the infectious disease like the COVID-19. So we must get the cooperation together and learn each other, and to facing any new epidemic wave. Still possible. Even Taiwan now is control well, but we don't know the next stage, next step. What happened will occur. So thank you for this very important online forum, and thank you to Peter to help us to join this very fascinating forum. Hopefully we have the next one. Maybe we can continue this online forum in different time. Yeah, thank you again. Thank you for everyone.
Thank you for everybody's participation.
Dr. Chen, thank you.
Stay healthy.
Thank you very much.
Good luck.
Stay
See you
healthy.
soon.
Thank you.
Stay safe.
Thank
See you
you.
soon. Thank you.
Bye bye.
Bye
Bye-bye.
bye. Bye bye. Bye bye. Then we may